Thank you so much for the introduction, and thank you for having me. It's been great to also hear from the other speakers. So I work in clinical AI. That's the name of our lab. And we work on several different projects. Okay, these are not the updated slides, I think. So I'll just talk about my work before I move through the slides. So we have four main research areas. The first one is related to in-hospital clinical decision support. So we have a lot of work related to multimodal AI in the context of in-hospital risk prediction. So we work a lot with electronic health records data, medical images, specifically chest X-ray images, clinical reports, and clinical notes. And most recently, one of my PhD students is also looking at ECG data. So we work with quite diverse healthcare modalities, and I would say each one of them comes with distinct challenges. So that's the first theme. And then the second theme relates to women's health. So we have one project that we've worked on for the past 3 years related to IVF, which also involves multiple modalities, specifically embryo imaging, patient clinical data, and we're recently also looking at clinician notes. And then the last two themes are more contextual because we work a lot with clinicians. So the third theme is more about the use of LLMs in healthcare, but specifically in the context of the Arabic language, because many of these models are now being benchmarked on English datasets, so we're also curious to know how do they work in different contexts where language could be a barrier. And then the final theme is also related to working with clinicians, so we look at what does the future of work in healthcare look like in the future, so what are clinicians interested in learning about in order to increase adoption in AI, but also to gather their feedback and expertise. So these are the four main thematic areas, but the one I'm going to talk about today is more related to in-hospital clinical decision support. So this is a recent paper actually that we just released a preprint, and we're thinking about multimodal learning here in the context of electronic health record data. So EHR, as some of you may know, it's a very sort of diverse source of data because it can contain vital signs, lab test results, procedures, ICD codes, etc. So it's extremely heterogeneous, and we've developed many models in this context, but one of the recent ideas that we've had is actually thinking about it as a RAG-based solution. Because one of the main challenges actually of modeling EHR data is that you have very long context. So in many of the recent foundation models, especially the transformer-based models, this could lead to loss of information, and they're also not very explainable. So in this project, we came up with this prototype-guided architecture. I'm not sure. Okay, so if you look at this figure here in the center, this is the prototype-guided learning framework, where we actually pre-trained the encoders and then learned to align the query chunk, which is basically the current visit of the patient, with their historical chunks. And we looked at different ways of actually chunking the historical data, for example, event-based chunking, time-based chunking, etc. And the paper has all of the results. And what was interesting, and you can find it in the preprint, and I had a slide for it, is that the model actually learns how to cluster the chunks based on the type of visit. So all of the outpatient chunks were clustered together, all of the inpatient or ICU chunks were clustered together, and so on. And that's interesting because then the model learned how to actually retrieve chunks based on severity, even though we didn't necessarily explicitly encode that in the learning framework. And it does improve performance significantly across different types of baselines. So now we're also interested in looking how would this translate to incorporating other modalities, because as I mentioned, this is limited to the modalities that are collected in EHR. And the other interesting part was that it's actually you can kind of understand the reasoning of the model because you can then investigate what kind of chunks were retrieved. And for patients who did eventually deteriorate or had bad adverse outcomes, the model was retrieving historical chunks that were also quite severe, which was also interesting to see. So we've also had a lot of work on, as I mentioned, multimodal learning, and Bara, a PhD student in the lab, presented his work yesterday. So we've developed different architectures for initially combining chest X-ray imaging with EHR, and that really started during the COVID-19 pandemic, where we came up with MetFuse. So that's sort of our baseline multimodal architecture, and we've built many other follow-up work like MetPatch, and most recently we're looking at how does agentic AI come into the picture So initially, we're looking at just the reasoning of the AI models in terms of how would they process the raw data. But now we're looking to go beyond that by incorporating tool calling, etc. So I think this is a promising area because when you think about deployment, I think one of the main challenges of actually implementing multimodal models is how do you actually get all this data together? Because in healthcare environments, the data sits in different servers and databases. So you have the PACS system, you have the EHR system, etc. So one of the deployment challenges would be actually integrating the data in a real-world setting. So with agentic AI, one promising idea would be, what if the data stays where it is, but then the agent just passes forward the sort of its reasoning and its processing of the data. So we're no longer relying on access to the raw data, similar to how federated learning essentially works, but more towards actually looking at data summaries instead of the raw data. So these are some of the things that we're thinking about, also keeping in mind real-world deployment. And we've had other relevant studies here. So in the first one there, we looked at multimodal learning in the context of associating stroke with OCT images of the eye. And this was interesting because we also had some discussions about where would this be used in primary care, secondary care, etc. But we managed to establish an association between OCT scans and occurrence of stroke. And incorporating clinical data actually significantly improved performance, both for our model, but also for an open source OCT model. And then we've had other follow-up studies that looked at specifically the learning dynamics in the multimodal setting, so the learning rate scheduler, knowledge distillation, etc. But a lot of our work focuses on multimodal learning. But this is our vision at the moment. So we recently got a grant from Adia Lab, which is Abu Dhabi Investment Authority. And this was actually a global call for grants, so if anyone's interested, you can check out the next round. This was the first round of this grant. But here we proposed basically creating Agenti CDS, which is an agentic-based clinical decision support system that basically builds on top of all of the foundation models and models that we've built in the lab, like MedFuse, MedPatch, etc. And the idea here is that we would have distinct agents that can process, for example, the EHR, a radiology agent that can look at images, and reporting agents that can deal with the textual summaries. And the initial results are interesting, but this is a work in progress that I thought was worth mentioning to this audience. So in terms of future directions, this is obviously the incredible team that I work with. We are interested in the following three questions. So the first one is, how can we continue to better synthesize multimodal clinical data, especially as we grow in scale? And in the context of model generalizability, because now we're also getting data from Cleveland Clinic Abu Dhabi and NYU Langone in New York. So we're also interested in seeing what kind of challenges may appear when you start looking at generalizing multimodal models. The second question is more related to safety guardrails. So, and I think this was also brought up by one of the speakers yesterday, is how do we quantify the uncertainty of the model in order to ensure that it is reliable in real-world settings? And we have some work related to that that's also published online. And then finally, how can multimodal AI systems be well integrated in clinical data infrastructures, taking into account constraints on latency, interoperability, scalability, and privacy? So we also have, one of my postdocs is actually looking at communication efficiency between agents and other questions related to, for example, spatial understanding and data grounding, because we want to make sure that the models actually rely on the core data. I had a slide about this as well. One of the things that we've noticed, for example, when it comes to chest X-ray imaging, is that the model, when you look at some of the state-of-the-art vision language models, even they perform well, they don't actually rely much on the base image. So even if you pass like completely out of distribution image, and we called it the snowman example, the model still generates a reasonable radiology report, which is not something that you would want to see in a real-world setting. So again, this is also related to multimodal challenges. So I think we have time for some questions because you got 5 slides instead of 10. But again, I'm very grateful for my team because they are the champions behind this work. We also got featured in the UAE Expo Pavilion in Osaka, in Expo Osaka. So we're very proud of this achievement. And we're also very thankful to our funders like the Meme Foundation, Adia Lab, and also some of our research centers at NYU Abu Dhabi. And if you're ever in Abu Dhabi, feel free to reach out as well. We'd be happy to host you. So any questions?
I really enjoyed your talk, and I was interested in. I think you'd suggested this idea of something similar to federated learning, where you were using maybe foundation models and language models to summarize data, and then taking that summarized data to analyze. Can you talk a bit more about that, just about that general kind of concept and what you're doing?
Yeah, so in that project, and some of the results are summarized in Agent RX, which is a benchmark that we recently released. So the main premise there is that each agent would basically process a single data modality. So you'd have an agent that processes, for example, clinical notes, another agent that processes the chest X-ray image, another one for EHR. Let me just bring up the image. This is the sort of core image behind this. And then there are different ways sort of to integrate the outcomes. So we looked at passing everything to single model agents and then assessing model performance. And we looked at the same tasks: in-hospital mortality, length of stay, I think. So the routine clinical prediction tasks versus passing everything to a single agent. And here we didn't incorporate any tools. So we were just relying on the reasoning of the agents. And I think one of the interesting findings is that once you actually move to this setup where you actually have multiple agents processing each modality, we did notice a loss in performance because either it could be because of noise that is propagated during this multi-agent integration. And we looked at simple multi-agent baselines, so debate, majority vote, and some of the recently released multi-agent baselines, but we did notice a degradation in performance. And we tried another thing. We actually tried creating like our own framework for creating better summaries, that are structured summaries that can then be passed to multimodal agent that can sort of integrate the findings of the different agents. But that also didn't perform well because it's very hard to actually come up with rules that summarize how you should process clinical data. So it's work in progress, and we also released the code, so if anyone's interested, you can have a look. But it's definitely a promising direction because it does overcome many of the data sharing challenges that you could encounter in real-world scenario. And in the single agent, we also noticed that the single agent is better at cross-modal reasoning because it's processing all the modalities at once. Yeah. Thank you.
Thank you. Any other questions we have? So in addition to the noise you mentioned, actually, is there any other challenges of using multimodal agent? How do you verify sometimes whether the agent connects the correct information you need?
Yeah, so we had a follow-up paper that's currently under review where we actually looked at the failure modes of the multi-agent systems. One of them actually is that within the multi-agent system, they start, depending on the complexity of the system, you actually notice different patterns. So as the system becomes more complex, it starts omitting or becomes less reliable in terms of processing the core modalities. So the most important modality here is EHR. And in more complex systems, they actually start looking at EHR less and less because they have other sources of information. So that leads to degradation in performance. And one other finding that we had in this initial study is when the multi-agent models start sort of either debating or like interacting with one another, it could also run into echo chambers where they just start confusing one another and further hallucinations. So I think we also need to think about more robust ways of actually getting these multi-agents to cooperate.
Great. Yeah. Thank you very much, Farah. Yeah.
Thank you.
Great. Yeah.